Hello, my name is John Gallagher, and this is my presentation called Lower Extremity Weakness. A 65-year-old male patient presented with several days of worsening lower extremity weakness. He also reported low back pain and numbness and tingling of the lower extremities. However, he denied saddle anesthesia, urinary retention, or bowel incontinence. He also denied a history of recent viral illness. All other systems were negative. For his histories, he had a past medical history of cervical stenosis with radiculopathy. He also had syringomyelia, prior stroke with residual right-sided weakness, transverse myelitis, prostate cancer, and cardiovascular comorbidities including hypertension, mitral regurgitation with a valve replacement, heart failure with preserved ejection fraction, and hyperlipidemia. His past surgical history included a radical prostatectomy for prostate cancer, and his social history included occasional marijuana use, but no tobacco, alcohol, or other drug use. His vital signs were notable for an elevated systolic blood pressure of 142 over diastolic of 74. His heart rate showed mild bradycardia at 46. Respiratory rate, oxygen saturation, and temperature were all within normal limits. For a physical exam, in general, he was well nourished, though in moderate distress. Respiratory, cardiovascular, and gastrointestinal exams were not remarkable. For neurologic exam, he was alert and oriented ×4 with no focal defects. However, he had reduced strength in his right upper extremity to 4 out of 5, compared to 5 out of 5 in the left upper extremity. Strength in both lower extremities was reduced to 3 out of 5. He also had decreased sensation to light touch on the right side of his body compared to the left. His gait was not assessed as he was unable to stand due to weakness. Bilateral Achilles reflexes were mildly reduced at 1+, whereas all reflexes were 2+. His cranial nerves 2 to 12 were grossly intact. For psychiatric, he was cooperative with appropriate mood and affect. Imaging was performed. MRI of the brain and brainstem was negative for acute infarct. In the MRI images of his spine, the following was observed. A T2 hyperintensity at approximately the level of C3 extending down to the thoracic levels on the cervical imaging. On the thoracic imaging, this hyperintensity was again observed, extending to about the level of T3. Finally, on imaging of his lumbar spine, disc herniation with severe spinal canal stenosis at the level of L2 to L3 was observed. The differential diagnosis included the following: lumbar radiculopathy, syringomyelia, cauda-equina syndrome, conus medullaris syndrome, stroke, transverse myelitis, and Guillain-Barré syndrome. For the patient's course, he was admitted and evaluated by neurosurgery. Due to poor surgical candidacy with many comorbidities, surgery was not recommended. Lumbar tap was performed, and the results showed pleocytosis, mildly elevated immunoglobulin, and 6 oligoclonal bands, concerning for inflammation. High-dose intravenous methylprednisolone was thus initiated, and the patient exhibited prompt clinical improvement. He was then discharged to inpatient rehab to continue his recovery several days later. Final diagnosis. The patient had findings of spinal cord inflammation on both MRI and cerebrospinal fluid studies. His symptoms were responsive to high-dose steroids. Thus, transverse myelitis was deemed to be the most likely cause of his acute lower extremity weakness. The etiology of transverse myelitis is generally idiopathic, although autoimmune and parainfectious causes are common as well. Pathophysiology involves immune-mediated inflammation and demyelination of the spinal cord. The time course is acute to subacute, with symptoms progressing within hours to 10 days. Diagnostic tests include MRI, which may show T2 hyperintense lesions, as observed in our patient, and CSF analysis, which may show pleocytosis, elevated protein, and illegal clonal bands, as in our patient. Treatment prognosis include high-dose intravenous corticosteroids for 3 to 5 days, followed by an oral taper. Most individuals have a good prognosis and recover completely. A brief review of transverse myelitis is also shown here, with possible areas of the spinal cord which may be affected, including the spinothalamic tract with effects on pain and temperature, the corticospinal tract with effects on voluntary movement, and the dorsal column with effects on balance and orientation. Thank you.